September Health in Hackney. I've got apologies for absence from Dr. Sandra Husbands and Canning, and welcome to Chris Lovett, who's the new Deputy Director of Public Health, who'll be presenting one of the items. In terms of just going through the usual pieces of housekeeping, because we're online, I'm not going to do the introductions. We can all see each other's names, and I think everyone's familiar. Just the housekeeping bits. It's being live streamed, it's being recorded, the press will be watching. Please keep microphones off unless you're speaking. Only unmute when it's your turn to speak. If you want to get my attention, please put up your hand. Please don't start using the chat in terms of another discussion going on, unless it's very simply to flag up the fact you want a question. When you're speaking, if you can please put your camera on. And that's about it. I've got someone who's a private caller on the line. Who's that? Can you just identify yourself? Who's logged in via phone? No. What one person there that's down as a private caller? Maybe called on the phone. Can you just identify who you are? Okay. Is that you, David? Okay. Well, we haven't got any.
David's joining now.
David's joining now. Okay.
I was going to say, I've just spoken to him as well, and he was having problems getting on.
All right. So then with that, then I haven't got any declarations of interest that have been notified to me. There's no urgent items in terms of or a difference to order of business now that David's here. As far as I can recall, the meetings were covered in the last meeting we had, and so that's why I don't have any minutes at the start of the agenda pack.
They're at the end, Councillor.
Oh, they're at the end.
Yeah, we'll deal with them at the end.
Fine. Then, in that case, then can I go straight to the item in terms of the integrated care system? We've got Mark Rickets, who's the chair of City and Hackney CCG, and we've got David Maher, who's the managing director. To very, very briefly set the landscape for everybody, obviously City and Hackney has its own CCG. In NHS England would like to create sort of super CCGs, and it's being proposed this is being done on a North East London footprint, taking all the 7 or 8 CCGs that are currently in existence in North East London. This requires the agreement of the members of the current CCG in Hackney to essentially agree to this new formulation, and I understand they're due to vote on it in October. And we have a presentation at item 4 from Mark and David. So I think, David, you're going to lead off. So do you want to give us an overview? And then I know a number of us have got some questions. So David, over to you, please.
Thanks, Councillor. So as Chair has outlined, we've been working on developing an integrated care system as part of the long-term plan in North East London for some time. I guess further context to the introduction is that we've been working in City and Hackney as a partnership, a long heritage of partnership working. As I said last time I was here, we attempted to devolve and pool our collective resources across the health and care system in 2016, but were asked to pause that by NHS England for a review of the governance. That didn't impede our continued work to develop and the Integrated Commissioning Board, which has been in place for some time, and we've consequently been working in increasingly collaborative ways with our providers through integrated work streams across health and social care. So to some extent, the proposal for a single CCG and an integrated care system in North East London plays very well into what we've already been doing locally. The pack outlines a set of stages or work streams and timings on slide 9. Just for your reference, we published the view of the future of health and care for people of North East London in August. We're going through a process now of engagement, both internally and externally, with various stakeholders, this being part of that stakeholder engagement. Our intention is to go to our GP members in October, certainly by the second week of October, to seek their endorsement that we proceed to form a single CCG for North East London. And the corollary of that is that we will be empowered then to mobilise our integrated care partnership working in City and Hackney, along with 2 other integrated care partnerships across North East London, one in BHR, aligned to the Barkinghaven Redbridge University Trust footprint, one in Walton Forest near Tower Hamlets, aligned to the Barts Health footprint, along with ELFT, and one in City and Hackney, aligned to the Homerton footprint, also aligned to ELFT as our mental health provider. There's a people process that's obviously ongoing. There's a piece of work that obviously needs to happen in terms of staff. They will TUPE to the North East London CCG, but the intention is that those resources and staff come back to, continue to work in the City and Hackney system, and in a newly reformed way under a neighbourhood health and care board, which I'll talk about shortly. Just to close off on the governance and the constitution development, so we've been working with LMC and our GP members on this. I think it's fair to say the plans we had in place, or the trajectory we were following at the start of the year, with a conclusion in October, which was our plan, certainly when we were looking out over spring and summer from a February viewpoint. We've had COVID, which has obviously compressed our opportunity to really get under the skin of the co-design on some of this work. That hasn't changed the requirement from NHS England that we move to a vote by October. So we are now rapidly orientating ourselves to engagement with our primary care network leaders, who will form the basis, I think, very much so, of the primary care leadership framework for the City and Hackney partnership. And those discussions are ongoing. And are constructive in nature. I think fair to say people want to see a bit more detail about terms of reference of the various governance structures that we're proposing. A lot of that work is intended to be co-produced, so we're not going to be able to land definitively the architecture for all of that by an October vote. But the paper's made clear that the intention is that throughout Q3 and Q4 of this year, we would be able to finesse, refine those, and of course, keep this committee updated on our progress. To move on then, just briefly to the integrated care model for City and Hackney. I have talked about this reasonably extensively previously at this committee, so I'll be guided by you, Chair, when I'm covering old ground. But just to recap on slide 12, this gives you a view of how the City and Hackney system fits within the NHS architecture for North East London. You see the starting position is our primary care networks and, of course, our communities. A set of place-based partnerships then working with local authorities across the 8 local authority footprint areas, the city being a local authority area in its own right, but we work collaboratively as a place-based partnership. And then the local systems, as I said before, Barkinghaven, Redbridge, City and Hackney and Well, comprising then the underpinnings of a North East London ICS. As we move through to slide 13, this is our current thinking on how we might organise ourselves for delivery and improvement across the partnership. At the top, it shows our patients and our residents with those principles of co-production, which have served us well to date. Aligned to that then are our neighbourhoods working working across our primary care networks. We're fortunate in the sense that the neighbourhood programme that we kick-started a couple of years ago now, in policy terms, fitted quite well with what then resulted in a requirement for primary care to work in a more networked way, and we're seeing the profits of that work increasingly. You'll see our partnership at all levels across the system, and then we move into a layer of transformation programs. Much of these transformation programs have been developed as part of the System Operational Command Group, which we put in place in response to COVID. That's been led by Tracey Fletcher from the Homerton, who's joined the call, and we've got our enabler groups supporting that, which have been in place across the partnership for some time, those being estates, primary care, IT, mental health and workforce. We're then proposing that there's a neighbourhood health and care board in place. That would be quite a strong, robust delivery board comprising of membership from across the partnership. It would be then responsible for bringing together our work programs and our improvement programs as a partnership, and then driving them through to delivery across our neighbourhoods and within our primary care networks. So we're in the process of debating and reviewing how that board is constructed, what support it will need. My view as Managing Director of the CCG is that the human resources that are currently under my management would increasingly align themselves to delivery within that neighbourhood health and care board, and thus retain our talent in the City and Hackney system for the benefit of our residents. Moving on then to the oversight and assurance layer, you can see the Integrated Care Partnership Board articulated. That's previously been known as the Integrated Commissioning Board, but recognising that we're moving into partnership ways of working, we're proposing to turn that into a broader Integrated Care Partnership Board. And as part of the accountability framework that we're establishing for this work, we would be including execs and non-execs from our provider partners on that board to help us shape decisions. The commissioning decisions, where necessary, will of course yield to the legislation that's currently in place, where there has to be a conflict of interest boundary to support commissioning decisions. But as much as possible, our intention is to collaboratively design those initiatives together with our partners, and then where there needs to be a decision taken that requires conflict of interest management, then we've got a process to do that. Finally, to conclude on this then, I guess the health and wellbeing boards are pretty critical on shaping the wider population health management approach that we take as a partnership. And that's increasingly more important as we look at the consequences of COVID in relation to wider systemic inequalities, both in terms of social determinants, but attitudinal issues. We're proposing that the health and wellbeing boards, would be supported by a new population health hub, which Sandra Husbands and I have been discussing for some time. It would then provide a locus of influence and coordination of wider population health strategies that we deploy across the partnership, and of course lend its expert support to the Neighbourhood Health and Care Board as it gets on with trying to improve outcomes for patients. The following slides then talk through some of what's changing, some of the benefits. I've outlined in what I've discussed about clinicians being at the heart of this work, is at the heart of the success of City and Hackney as a CCG, and we aim to emulate as much of that as possible in our new model of working. Decision making being at the place, unless it satisfies one of the tests that are outlined on the following slide, that being a sense check of does doing something at the North East London level improve our chances to improve population health or reduce inequalities? Will it help us make decision making smoother or quicker? And does it align accountability for decision making, accountability for money? Which I guess brings me neatly onto a discussion on the money. Slide 16 sets out a commissioning and finance framework for the integrated care partnerships. It states that circa 98% of the existing CCG allocation will be devolved back to City and Hackney for our deployment through the Integrated Care Partnership Board and the Neighbourhood Health and Care Board. The single CCG at North East London then will retain a corporate budget for head office costs, so that's 1%. So bearing in mind that the CCG staff will be employed by the North East London CCG, that is a necessary bookkeeping that budget is retained there. And then a 0.5% contingency and a 0.5 risk reserve, which is already something that we as a City and Hackney CCG hold every year. So it is perfectly logical that the North East London CCG would hold that risk reserve too. And just to note, these allocations are subject to national policy, and post-pandemic resources may differ as we understand the comprehensive spending review plans. But I just note the BBC kind of headline stating that the Chancellor is deferring his review to support COVID during winter. So we're working on the basis of our current allocation in those models. The final slide talks through some of the principles. I've alluded to them throughout this presentation: co-production, clinical leadership. We are fortunate in City and Hackney that our providers are high functioning, so performance has never been a key issue area of concern for us, but we're all driven, I think, by quality and ensuring that our services are of high quality, and therefore we're proposing to put a particular emphasis on quality in our new ways of working. I've outlined primary care leadership. We're proposing that the clinical executive committee that forms part of the CCG would be reshaped to include and provide the primary care network directors with a leadership fulcrum from which then they can help support wider changes at a primary care level. There's an accountable officers group that has been in place, which includes the chief execs and senior managers, myself included, from the partner organisations, that provides us with a good executive basis to help shape these decisions. And there was obviously our Integrated Care Partnership Board will include non-executive leadership, included elected members, which is already the case. And then the final slide gives just some links for people to peruse and provide further feedback. As I said, we're committed to building things in City and Hackney, so we want to get this right. So I'm keen to hear your feedback and questions.
Thanks, David. That was a comprehensive overview, and you answered some of the questions I had. I suppose before I open it to questions, I mean, obviously, we've got an outstanding CCG, we've got an outstanding hospital. There's obviously, questions about on a Hackney level whether we really need this change, but I appreciate there's a sort of a diktat from above as to how this change coming down the line. What concerns me at the moment is that we are being asked to consider it, and also your members are being asked to consider it without the actual constitution in place, and to actually see the formal agreement as to what powers they're giving up and what the agreement is. Because at the moment, the sort of the 80-20 split, the fact that 98% of money will still be devolved to place, they're essentially worthless in contractual or agreement terms once your members have given up their power. So it's essentially the lack of assurance without seeing the constitution they're voting on.
I think that's fair. The constitution is being developed, and there's a further draft went out to our GP partners this afternoon. I think less of a concern to our local partners is necessarily the North East London constitution, but actually the working arrangements locally and how we shape those. I think that's what we're hearing from our members. They're looking for greater clarification sooner on how the Integrated Care Partnership Board will work and how the Neighbourhood Health and Care Board will work. So I recognise your feedback too. That's my doorbell, which I'm sorry, I'm just going to mute myself, and maybe Mark can pick up the conversation.
Just with that in mind, just before we focus in on the local system, maybe just talking about the constitution on CCG and arrangements at the North East London level, and that you're describing the scheme of delegation and how the principles of subsidiarity will be maintained going forward. Certainly, we will. The constitution is being worked on, as David says, so there will be a constitution that members will see and have seen drafts, and that's being worked on, and people are feeding back. It is essentially focuses on what a CCG has to do still under the legislation, and where it gets into the detail, it refers to the handbook, the operating handbook. So the operating handbook will also be ready for members to see, and that will describe the financial framework in more detail, all the sort of arrangements of how the money is transacted down through the system, and also those are the allocations we know about. There's also new money which will hopefully still come as part of the long-term plan, and how that will be managed as well as at a North East London level. It's important to remember that already the allocation, there's been an adjustment in the way the allocations are made this year. So we had months 1 to 6, and then we had to wait for months 7 to 12 to be announced because of the extra challenges of COVID and the spend around that. And that money is now going to the North East London. So that will then flow through the systems according to previously published allocations. We get the 98% of that, et cetera, we get all the primary care budget.
I suppose
those changes are already afoot with 7 CCGs or 1 CCG. So we will get quite a lot of those details. And the other document I was going to say that we've worked on, and I've worked on a lot with, particularly with Sam Etherington, my equivalent in Tower Hamlets, is what we call a declaration of principles, which all CCG chairs and the CCG exec have signed up to, which basically articulates the principles against which we'll be judged when moving into the future. So, that will also be circulated to all members as well. It already has been, actually.
I suppose my concern is, and this will be my last sort of question or point before I invite other members to come in. I mean, my concern has always probably been more the medium to long term analysis of this, because at the moment, under primary legislation, under statute, it's sort of, you are a body, you get the money, whatever it is, 450 million a year, you commission the Homerton, that provides a solidity and a backup to the health framework in Hackney. And the concern is, without a formal written agreement, we could be 5 or 10 years down the line when none of us may actually still be here in our current roles, but people at NEL level decide that they don't want an acute provision at the Homerton or something like that, and they think that would be better furnished at Barts. And then at the moment we are the commissioner for the Homerton. But I mean, it's that sort of medium to long term concern that I have, that we have a protection over our own health economy. You can call me selfish for saying that, and perhaps I should think more globally. But under this new arrangement, if we agree it without seeing the Constitution, what guarantees do we have medium to long term?
So, Councillor, I don't think that detail would be articulated in any constitution for a clinical commissioning group. Its responsibility is to purchase services for its population. I don't think it would necessarily get into the detail of discriminating in terms of where that provision would come from, other than to align itself to
but I'm talking about the real politique of how those decisions are made at an NL level vis-a-vis a Hackney level, which they are at the moment.
Well, I think what plays to our strength is, I think, the framework that we've landed on for North East London, which is City and Hackney recognised as a subsystem within the wider integrated care system model. So Tracey, as one of our executive leads, will be a part of the executive leadership structure at that North East London level. She will also be part of our local executive team in City and Hackney. So there's a good tethering of accountability back to the local system in that way. Equally, the CCG does need to represent the people of City and Hackney. So the accountable officer of the CCG will be tethered back to the Integrated Care Partnership Board and be held to account for the framework that we've established in terms of the commissioning and finance framework that I've just outlined in the paper. So I think the counterbalance to detail in a constitution relates to the accountability framework that we establish, and using our wits to kind of ensure that we get the best outcomes from the collaboration framework that we've put in place. I am expecting that the mandate from North East London will include this detail, that it will say the City and Hackney system is expected to deliver a set of outcomes for our residents that are in line with our requirements as a commissioning organisation. And I'm expecting also that would be clear about what resources are available to us to do that. And it would be within that mandate that some of that detail that you're describing would be held. But the real politique, I can only reassure you that I think the accountability frameworks that we've got are probably the best shot we've got of managing those.
Okay, thank you. Right, now I see questions. I know Cllr Oguzkanli is first, but actually Cllr David in the pre-meet said he had a question. So I'll take Cllr David first, then I'll come on to Cllr Oguzkanli. Cllr David.
Yeah, thanks for the presentation. There's quite a number of, well, let's just say 3 things which I'm going to touch on, which are, I mean, parts of them have been spoken about by Ben. I think in terms of the accountability, I think it's not particularly very clear the way you've set things out. You've mentioned the Constitution has been shown to your members, but we haven't seen it. It would be helpful for us to catch sight of it to see where there might be some anomalies. in terms of dissolution, because you did mention that some parts of the Constitution would not address certain issues which Ben mentioned, but the Constitution should make provisions for how dissolution would take place if there is a need for it somewhere down the line. So that's something I think it would be nice for us to see. In terms of the resources, it mentions here that 80% of the decisions would be made locally and 20%, I would imagine, would be centrally. But then how do you define 80% and how do you define 20%? Is it decisions about money, or is it decisions about, operational contingencies and plans? And then the 1%, I don't know if that's particularly the best value of money. 1% alone goes straight into admin fees, admin costs, as the case were. So if you could address those issues, and in terms of the Constitution, if we could we have a look at a copy, and then perhaps it might be a better thing to defer your decision until we can look at all these things, and especially the Constitution, to make a fair comment. It's hard to make a comment based on just what you've given.
Thanks, so I mean, by all means, we will share the Constitution with committee members.
Sorry, if I just want, sorry, just to cut you in. One of the examples of the situations which I am particularly keen on is like the situation we had in Homerton with the ISS contract. So there are certain provisions in constitutions which, one way or the other, could affect the wider community interest. So that's that's where I'm coming from. But then, yeah, sorry, go on with the point you were making.
Well, I think on the specifics of that example, I'm not sure the Constitution, again, back to the point I was making earlier to Councillor Hayhurst, would kind of illustrate parameters for that kind of work. Again, it would emphasize kind of best value principles. But by all means, we shall share the Constitution. It is a pretty standard model Constitution from NHS England, so it's not something particularly that we have huge authorship over. It is a framework that's been established nationally for CCG constitutions, but by all means, as I say, I shall share it. In terms of, you'll have to beg, excuse me, it's been a long day. Your follow-up question related to administration costs, and there was something else in the middle.
And then the 80-20 in terms of how do you define 80%?
You mentioned dissolution as well, making sure the
and then, yeah.
I'm just looking at the Constitution now to make sure those sorts of areas would be covered, because we would expect that in any standard. The reason we haven't just circulated it now is because it's being worked on by the members, so they're kind of having a chance to feed into it. But as David says, there's most of the nuances will actually be in the operating handbook rather than the actual standard Constitution itself. But very happy to share it with you. You mentioned deferring the vote to give us more time. We wanted to do that because of the time we lost because of responding to COVID. And NHS England said, no, you've as North East London, you've already had an extra year. Other STPs in London, apart from North West, which also did what we did, which is going extra year, you've had extra time to sort yourselves out. No, you're going to get on with this. So we are very limited in what we can do in terms of wiggle room. And so we've had to kind of come at this with renewed pace when we've had some time and space, practically speaking, when COVID, the pandemic, the first peak of it had calmed down. We're also working in the context of COVID and standing up all services, safely again. So life is busy. So we would have liked to have been a bit further ahead with saying, yes, Constitution finished, here it is, plenty of time to look at it. But I have to apologise that we haven't been able to get it to that stage, yet.
Okay.
But it's being worked on, and we will share it with you.
So
yeah,
David,
there is just this quick one. If the Constitution's not been set in stone, then I hope there are mechanisms for how to amend the Constitution, and then there would still be scope for doing that along the line.
If you make any amendments to the Constitution, they have to be agreed by NHS England. So to some degree, whereas the operating handbook, we have much more. We don't have to agree. NHS England can't step in when we talk about the handbook. So the Constitution refers to the handbook a lot. So some people want clarification about when that point happens and what goes in the Constitution, what doesn't. If you're in the Constitution to change it, once it's been signed off by NHS England, you have to get NHS England's agreement again. That's the power they have.
I've got other members who want to come in. So David, can you quickly address the 80/20? Is that based on financials or other metrics? And the 1% admin costs, please.
So the 80/20 principle was something that was put forward in the very early days of discussing the ICS framework, and it was intended to illustrate a position that local devolved power and autonomy would be, at a maximum, well, not at a maximum, at a de minimis level of 80%, with 20% possibly being done at North East London level. As we've got clearer on the detail, and as I've illustrated in the slide on the finance framework, it's much closer to 98% of the financial resources sitting within the City and Hackney system. So the 80/20 got us on a journey of keeping people focused on getting stuff back to place, and in many ways has helped us win that argument for the allocation that's illustrated in the slide. So,
but David, it's based on finance. It's based on the 80/20. Kofo's question, what's it based on?
No, it's everything, Ben. We talk about 80/20 principle. It's really important to say it's just a principle. It's not a rule. It's not a percent. It's nothing. So when you think about, what goes on where, we talk about it. Oh, that's something that's in the 80s. That's in the 80s space. You can relax on this now. We'll take it. We'll be doing that locally, or the staff. They'll all be employed by the CCG, but we'd expect them, a single CCG, but we'd expect, no, most of them will be working in the 80 place. And of course, already some of our staff do work across NEL, they have blended roles, but most of them, no, that's at 80 place. So it helped us, as David said, win the arguments. Now we're seeing in more locked in ways, so the money, you've just seen, the staffing, David's already alluded to, the activity and the scheme of delegation, will also follow the 80/20 principle. So it's just helped the debate move on until we can clarify each individual area. So I wouldn't want you to see it in any other word terms than that, really.
And David, the 1% on the admin costs?
Well, as a CCG in City and Hackney, we, as a clinical commissioning organisation, we have a running cost allowance which is set by NHS England. We in City and Hackney have always underspent our running cost allowance by, about almost 20%, which has gone back into frontline services and funded things like enhanced primary care and other things. There was subsequently a requirement from NHS England that all CCGs need to deliver a 20% efficiency in their running costs. Our partners in Walton Forest, Sir Hamilton, Newham have come together as a collaborative set of CCGs, and they've already teased out some of the efficiencies that are required in administration by doing that work, and BHR are going through that process too. So whilst I recognise that globally it looks like a large sum, and it is a large sum, it is a running cost allowance that is set out from NHS England for CCGs to run their business against. We will need to take a long-term view about value for money for a North East London CCG and whether we view that working well. But my impression from the 98% resources that is outlined in the pack, we're going to require our best people that already are in this system working for us to continue to do their good work in the framework we've outlined. So I view them as being excellent value for money, frankly.
Okay, thank you. Cllr Oguzkanli. Dennis?
Thank you, Chair. Every few years, we seem to be making significant... Can you hear me?
Yeah. Yes.
Can you hear me, Chair?
Yep.
Yep.
Every few years, we seem to be making significant changes, and this is one of those changes. And I question whether a case for this change is made out. I also question the timing of the change, given that we are in the middle of a pandemic and resources and finances and then valuable time and effort needs to be spent in tackling the pandemic. I have serious concerns and issues about the accountability and local involvement, because we're talking about 7 CGCs from 8 local authorities merging to 1. I also question how much this commission can contribute when a clear case is not made out and when we haven't seen the Constitution. I agree and echo the previous comments made by the Life of Constitution by the previous questioners. I also want to know how much these changes going to cost and how much you take away from the valuable resources that we desperately need now. And whether pressing ahead to October voting is a sensible thing to do. Thank you.
David? You're on mute. David, you're on mute.
Excuse me. Thank you, Councillor. I mean, some of those are reflections which I guess I would empathise with in terms of the direct question around costs of change. I mean, fair to say that we have, as I said, a CCG running cost allowance. So change is being developed within that framework, and the costs are being extracted to align with the 20% efficiency saving. Are resources being faced in the right direction in our response to COVID? I would say we are doing our absolute best to keep on top of all the detail, including COVID and these changes, which, as I said, are running against a timetable that is not set by us. That's as much as I can say. I'm sorry.
Just on the accountability governance, so just to go back on this, I think in your opening presentation you said that the Constitution won't be ready by the time of the vote. So what will the actual members?
Sorry, so I didn't say that, Councillor.
Sorry, okay, I misunderstood.
Yeah, no. I mean, that's exactly what the Constitution is the material detail that members would be voting on. It's a critical part of the process. So it will be ready. As I said, there is a draft that went out today. There will be further drafts of that over the coming days. I know there's a meeting with the chairs of the CCGs tomorrow morning. So yeah, no, I'm sorry, you misheard me there.
No, sorry, I misunderstood. That's my fault. And the handbook is that will also, that Mark's been referring to, that will also be fleshed out in more detail before the vote.
In as far as is possible. As I've said in the timetable I've put in the pack, you know, much of the finessing of this local partnership work, although we've got the good bedrock of it here in terms of our integrated commissioning board and the framework that we've got for organising ourselves through integrated work streams, we want to use Q3 and Q4 to really get into the detail of that. And I'm leading a process with the Integrated Care Partnership Board, consulting with key partners and stakeholders on how the Integrated Care Partnership Board develops. Tracey Fletcher is leading a process on the development of the Neighbourhood Health and Care Board, engaging with key members on working out and finessing the membership, how that's going to work, what its kind of ambitions are, and so on. So certainly as we develop that handbook in that detail, we will keep you updated here and keep checking in.
Yeah, fine. I mean, I think, yes, we clearly like to, I think, see it as soon as we can, both the Constitution and the handbook. And then I think we'll probably have some sort of representations to make and in writing to you on those, just so we've formally set out our view. Councillor Spence.
Hello, can you hear me?
Yeah.
Yeah. I wanted to ask David and Mark if they could remind the Commission about the original premise behind this exercise in centralisation of the CCGs in North East London and elsewhere. For me, it would be helpful to just have that brought to the fore again. It seems to me that there's some issue about the relationship between the purchasers, the CCGs, and the providers, and a question about leverage. But I'd like some answer to, or a reminder of what the original premise is behind this whole exercise.
Thanks, Councillor. the long-term plan set out an expectation that all parts of England would be the health services would be organised within an integrated care system, working across larger population footprints of 1 million plus. And at the same time, it set out an expectation that primary care services would begin to organise themselves within primary care networks, working with a much more granular population level of 30 to 50,000. So the intention was that by leveraging providers and commissioners together at a wider population footprint, it gave greater scale to enable grassroots change and improvement working and operating through primary care networks. There was also a side letter to, or certainly a foreword to the long-term plan, which Simon Stevens, the Chief Executive of NHS England, laid out his stall, I think, or certainly NHS England as a commissioning board stall, that they viewed that legislative change needed to happen to remove competition from the market and reduce this requirement for commissioners of services to use market forces to define best value. I don't see that currently playing out in current legislation, but it's certainly there as part of the NHS Commissioning Board's intention. And I think that was part of the driver of bringing providers and commissioners together to do that planning in a joined up way, was to kind of break down those boundaries between purchaser and provider, and thus lend itself to greater robustness to be able to manage market forces until legislative change is in place.
Yeah, and Dave, so yes, I was referencing the long-term plan is the genesis of much of this work, but it does allow us to come away from that traditional contractor-provider relationship. You know, it's a kind of workaround until legislation is changed. So it allows us to really move on to, which is some of the exciting stuff, which is about, you know, moving from those contractual formal arrangements into something where we all come together to share planning, to share responsibility for accountability framework, share the financial management of the system. We've got this much money in the City and Hackney system. How do we best spend it? We hold each other to account. There are levels, checks and balances across the system. There's still a need for CCG, so there'll be a subcommittee of the single CCG within our system at the Integrated Care Partnership Board level. So those checks will all be there, but it allows us essentially to really move into this shared way of working, where we are all accountable and we hold each other to account. We manage the population health in a much more holistic way, and we rally the resources we all have to the greater good, and that allows us to step into a much more ambitious kind of areas of prevention and the wider determinants of health, and really engage with the voluntary and community sector, the communities, and have this model where we're working busily at the City and Hackney level, and the key driver of how things will be delivered will be at a neighbourhood, this 30 to 50,000 sort of population size, and then we have things that go on across the STP, the North East London level, which they do already. You know, we already come together to contract, you know, things like London Ambulance and things. We don't do that individually anyway. So that stuff will still carry on at a bigger level. And there are other things that will come on at that bigger level, like money flowing through it, new money flowing through it, specialist commissioning kind of coming into it, flowing. There's lots of things. So that's why we need to be absolutely at that STP table. And Trace will be there, I'll be there. You know, others will be there doing the work at that level as well. But this does come with opportunities, this change. I know it's not of our making, but we're going to make a damn sight, you know, good job of making the best of it. And actually, the best of it could be really good, could really help us have a stepwise change in what we were trying to do anyway.
Okay. Thank you, Mark. Cllr Adams.
Thank you, Chair. I just want to go back to the question that Dennis asked about how do we maintain the local accountability with these 7 CCG from 8 boroughs. And I'm not sure that question is actually well addressed. Can you please tell us how it's going to work? for us to have confidence in what is being proposed?
I'll do my best, Councillor. So the CCGs are made up of members' forums. So every GP practice is a member of the CCG. And the current accountability structure works locally, that we have a chair, which is Mark, and there is an accountable officer, which is Jane Milligan, and I'm her delegated representative in the City and Hackney system. And you hold me to account in this way. I'm held to account by the governing body. I'm also held to account with Mark through the members' forum locally. So that's the current operating model. The future operating model is actually not that different. The future operating model is a CCG at North East London, 7 members' forums locally with practices, members of that, and they are the owners of the Constitution. They will elect a chair, similarly as to what they do now. That chair will form part of the North East London governing body, but they will also be part of the integrated care partnership structure locally and sit on the key decision-making bodies in City and Hackney. Jane Milligan, as the accountable officer, will also be held to account here locally. And because of the integrated care system model, which includes provider executives working on that system, we will also have our executive leads from our key providers also sitting in the accountable place within the Integrated Care Partnership Board. So the accountability is very much locked in locally and subject to scrutiny from local committees such as this. Plus, we will continue, of course, to have our excellent health watches, keeping a very close eye on everything we do. So I hope that gives some clarity or illustrates that framework in a bit more detail for you.
And David, can I just clarify? So essentially, under the new system, both you and Dave, the equivalent roles of you, not the equivalent, but you and David remain essentially, but in different defined roles. Is that right?
In the sense of, sorry, is that a question to me, Councillor?
Well, yes. I mean, yes. So do we still get, say, to this committee, do we still get somebody who is a sort of chair representing the sort of the primary care doctors in the capacity of Mark, and do we still get Jane Milligan's sort of delegated person in terms of the City and Hackney local system, in terms of the management of it, in terms of you?
100%. I would say you get more bang for your buck in terms of accountability, because we will be including our provider partners in the shaping of our decisions locally. So Laura Sharp is on the line. I see Tracey Fletcher has joined the call. Equally, ALFT as our provider partners in the partnership will also be available for scrutiny through committees such as this. So I think in many ways that's an enhancement from the current model, which is just me and just Mark. It widens it out to the wider partnership.
And finally, just on governance structures, I mean, the governance structure for the overall North East London ICS, I mean, how unwieldy is that going to be? Chairs of trust boards, elected mayors, 20 people holding another 20 people to account. I mean, how practicable is that?
Well, I think that's why we can be confident that with 98% of the resource flowing to the local City and Hackney system, that we stand a good chance of getting on and making the changes that we want locally. But I think the nature of responding to COVID and managing health services in this new environment does really require something akin to the ICS board with the ICS executive. And I can't speak for Tracey, but I know she will want to work very closely with, and does work very closely indeed, with provider partners across North East London. There's an Acute Alliance that has been established to try and get services mobilised in a safe way. That will require some changes and locus of expertise across North East London that I'm sure Siobhan will allude to in her presentation on planned care. So, it is important that we do that work with our partners across a wider geography, because that's the nature of trying to coordinate health services in an equitable way.
Okay, I think we're out of time on this. I think in terms of sort of next. Oh, Tracey, did I see a hand there?
Yeah, if you've got 2 seconds,
yeah, go for it.
Mayhurst, I think just to support from the you made a comment about the acute services, and David's just talked about the benefit of North East London on the acute side. So 2 comments on that, and then 1 comment generally on the changes. So firstly, actually quite a lot of the emphasis on what we can provide from an acute perspective locally is probably determined more by regulation. So not by commissioning, but more by regulatory bodies and assuring that we're able to provide those sorts of services safely. And you might remember changes around the stroke services. That actually probably was a very good change, and was done at London level and was very much associated with what should be the minimum requirements to provide those services. So any changes at that sort of level really have probably never sat with the CCG, but much more in the regulatory framework. And we and us collectively need to make sure that we continue to do what we should do and actually don't do what we shouldn't do. And I think that's really a really important distinction. Therein leads to the advantages of working at a North East London level. So one of the things I think I probably can definitely say is, and it may be just during the COVID period, but it's going to lead into different ways of working. During the COVID period, relationships have improved between the acute providers, and you will be aware that we do not provide all of the services that are necessary for Hackney residents. And one would hope that for North East London, these arrangements would actually solidify better the need for us to have inpatient ENT services, for example, clear pathways for neurosurgery, and some of the specialist cancer services, which we do have, but are patchy, and this should lead to us having more leverage to improve those. And as in City and Hackney, there is more responsibility across the patch now to make all of those pathways work. And likewise, we at the Homerton will be a provider for particular services, particular specialist services as well, and continue to be so. And we should be. Neonatal services being one of them, bariatric surgery being another. So that's on the acute side. And then finally, I think really just to emphasise what, or to reiterate what Mark was saying as well. So it's very easy to talk about what we may lose out of these changes, but there are also opportunities to really gain. And we do expend an awful lot of energy and an awful lot of angst in this commissioner-provider battle, if you like, and then provider-to-provider battle. And one of the key shifts we really need to achieve through this process is that sharing of responsibility, which I know is easier to say than necessarily do, but a different financial regime is almost certainly going to come in, if it's not come in already. And with that brings different challenges, but also different opportunities to operate as a system. Arguably, there's many around this table that would say it'd bring different pressures on us as an acute trust and different incentives for us as an acute trust. Nevertheless, it's going to happen. And I really do think that the removal of this battle of commissioners and providers locally, and the emphasis being on making the system work collectively, I think is an opportunity we should emphasise rather than only talking about the loss.
No, I can understand that. Thanks for that, Tracey. That's very helpful. I think because we're over on this, I'm going to bring this item to a close. I think in terms of sort of next steps, if we can please have the a copy of the Constitution as soon as it possibly comes back, and you've looked at it again, following your first draft out, and the workbook. And if there is any further forward on the overall North East London Constitution as to how many people are sitting on what governance boards, to see that as soon as possible. But I think we'd certainly like to see it in good time before it goes to the members, so we can we can write with our views on it. So can I ask that? Thanks everyone. Tracey, can I just ask you, I just want to get a 5 or 2 minute update on where the Homerton is re-COVID. So and the next item is about that. So can I just ask you to hang on for a minute just to ask you about that for the start of the next item? Is that okay? Thank you very much. So what I'll do there is I'll close that item. Thank you very much, everyone. Thank you. The next item on the agenda, item 5, is to do with test and trace in Hackney. As I've said we've got apologies from Sandra Husbands, but welcome to the new Deputy Director, Chris Lovett. Before Chris kicks off, I just wanted to get an update from the Homerton side. I think as of 2 or 3 weeks ago, I think we got the message through that there may be a few people who'd come through admittances in terms of COVID patients. We've obviously now have a situation where probably everybody who wants a test in the public isn't able to get it. So a key metric then starts to become, albeit it's too late at the point of hospitalisation, but how many people are in hospital. And I think there was some modelling going on earlier on the week that would perhaps by the weekend we could be at the equivalent levels of we were at the 18th of March levels. In terms of hospitalisations. I think that was coming out of the independent SAGE group and the modelling they did. Where are we at from your perspective? How many numbers of patients have we got in the Homerton at the moment, and what trajectory are we seeing, Tracey?
So thank you, Councillor Hayhurst. So this morning when the report came out, we had 4 patients in the hospital and 7 waiting for tests, results to come back. We haven't seen yet the level of increase that BHR are reporting. So BHR are reporting many more numbers at this moment in time. We have seen a very small increase, and it'll be interesting to see how those 7 come back. That is a greater number that we've seen in terms of potential positive, so symptom related positive, but we had 4 this morning. I suppose it's just to add, we are now, as you would expect, in the midst of planning and already reorganising to think about an increased level of admissions in light of the expectation that is going to happen over the next few weeks.
Fine, thank you. And are you in regular contact with? I presume the answer is yes. But in terms of feed. I mean, it's just in terms of the monitoring because of the paucity of the testing data, and it's hard to see. Are you in sort of daily contact with Sandra and Chris, sort of saying this is their admission levels at the moment? So so there's a joined up sort of data analysis going on across admissions and testing.
Yeah, so Chris and I have actually been in, so Councillor Kennedy and I have been in email exchange only this week actually about making sure we exchange data, and we agreed to do that. I think on reflection we probably need to agree to exchange slightly more regularly than we thought. We're going to swap weekly packs, but we may need to go to much more frequent than that. But yes, anything that I need to keep councillors updated on, I'll pass through Chris them directly.
Fine. And just very briefly, obviously care homes, I know certainly Mary Seacole were 1, but there were 4 main care homes in Hackney. There were significant numbers of mortality, sadly, in the last wave. Obviously, there's been a lot of talk about discharging 2 care homes, and at what stage, and with people still being positive. What are we doing from your end? What are we doing differently this time than we did last time on the care home side?
So actually our discharges on the care home side, and well, certainly Mary Seacole, we had a very good record there. I think one of the key factors in how we manage this is how we work with the care home staff to make sure that there's as much minimisation on any sort of transmission as far as possible. We test patients throughout their admission and before they go, but I mean, we were transferring patients out, and on some occasions it's almost more risky for patients to wait in hospital than it was to transfer to care homes. And one of the things we've got to be absolutely clear about is making sure that the infection control procedures in care homes is as good as possible, because they're actually possibly safer there than they would be staying in hospital.
Fine. Thank you, Tracey. I think Councillor Adams has just asked how many people we have in ICU at the moment. I mean, I mean, are you able to say that?
One COVID patient.
One COVID patient.
Well, there are more patients than that, but,
yes, yeah, but one COVID. Okay. Tracy, thank you very much indeed. That's much appreciated. And then can I ask Chris to start his presentation?
So thank you very much, and good evening, everybody. So Sandra Husbands has sent her apologies, but she has asked me to present the latest data. I know a number of you have sat through this already today, and I'm slightly conscious of time, so I will be fairly brief on the data. There is an overall theme and a trend. Essentially, if it moves forward, it does. Essentially, the difficulty we have now is all about the availability of testing. So previously, if we go back about 4 weeks ago, we had pretty good confidence that people who are symptomatic with COVID would be able to access a test. There were quite a lot of differences about whether that was those tests were being taken up at the same level amongst different communities, if people didn't have English as a first language. But essentially, you were fairly confident that people were going forward and getting tested. The difficulty we have now is the really extreme availability of tests, not only in Hackney, but also across London and elsewhere in the country. So what you're seeing in terms of cases is almost certainly not a reduction in the number of COVID cases that have been newly infected and in the community. It's about the availability of testing. So this has to have a degree of caution with it. And I think triangulating this data with data from primary care and data from the acute hospital is going to be really important. So you can see here on the second graph, the number of people testing has really fallen off. And what's causing us concern is the fact that positivity is going up, which is an indication.
So Chris, sorry, we're going from right to left, are we, in terms of the second graph down, persons tested on the right-hand side was a few weeks ago, and on the left-hand side is now.
So the scale is right at the bottom. So it's a similar scale. So May is on the left, and September the 11th is the last data entry that we have there on the scale. So what you can see is that the number of cases has steadily gone up, but then it is dropping off. And that's because of the number of tests and the number of people, the percentage of those tests which are positive is increasing.
Yeah.
Okay. And then really the other area of concern is, I'm sure everybody heard that in the summertime, the increase in the cases was predominantly amongst the younger population. We're now seeing that change, and that we are now seeing a shift with more of the older population getting COVID, who are being able to get tested. And this is obviously going to have ongoing issues, as people who are older tend to have more complications with COVID. And then this gives you a distribution map of where the cases are as a fairly low geographical level. And you're finding in the north of the borough, as we know, there is an ongoing outbreak in that part of the borough, and fewer cases in the south of the borough. And then this gives you the data as a rate, and you can see again, this is in the last 7-day period, that we have got a very large difference in the numbers. Again, caution about the availability of testing, but it is giving an indication that the rate of COVID infections that are being diagnosed is quite different, and is pretty much a north-south split in the borough. And then this gives you an indication of the sort of the daily variability in 3 of those really high outbreak level wards. And then if you're looking at trying to triangulate the data with other sources, so this really is giving us a sense of what the healthcare seeking behaviour is like. So we've got the suspected cases that are going into primary care, those people that are phoning 111, and the staff-related absences. And this is quite different from what you saw at the beginning of the slides, because this is not dependent upon testing. People who've got symptoms have got to self-isolate. This is also a really key issue in relation to the impact on services. If you cannot get a test and you're symptomatic, you must self-isolate for those 10 days, and your household must also self-isolate. And so obviously, if we can't get the testing sorted so that key workers as well as members of the public can get tested, then you are going to get increasing staff absences. And we're seeing that in schools, and we're seeing that from primary care, and no doubt also in the acute trust as well.
Chris, can I just say it's great to see the triangulation of data there for 111 calls on primary admissions. I haven't seen that before. It's wonderful to see that we're looking at it from every angle.
And I think that triangulation, I mean, I'll come to that in a second, but this is a summary of the national the national announcements. Some stuff in here is very welcome and long overdue. simplifying some of the rules about face coverings, ensuring that some of the government guidelines are now actually written into law. So COVID, the COVID secure guidelines now become a legal obligation. That's going to really assist in all of the enforcement agencies and having conversations and saying, no, if you do not comply, we will be able to issue you with fines. And then obviously there is quite significant impact on the hospitality industry of some of the closes that some of the measures that will require early closure. And then just to give you a quick summary of what we've been doing. So there has been a multi-agency outbreak control plan. We have tabletopped it recently. We are got lots of standing operating procedures. They do need updating, and we're in the process of doing that, but they do cover things like schools, workplaces. We've been working very closely with the universities as well. So there is a good outbreak control plan in there. We have got an incident management team for the outbreak in the north of the borough. We're doing that with colleagues across the different borough as well. And that is been looking at doing week-long actions to promote social distancing, mask wearing, engaging with a number of the communities in the north of the borough to make sure the messaging, especially around some of the religious festivals, has been really strongly communicated. And then in terms of the COVID statistics, I've been very keen to work with our partners in the NHS so that we are able to put into a single metric. We do have to be careful about small numbers. There is always going to be this concern that a lot of the data that we're allowed to publish, if it's less than 8, we either have to do it as a rate or redact it. But I am confident that we can make sure that there's a much better view of the impact of this on all of the systems across the NHS and social care. Really welcome news. I'm sure it's going to be a little bit of a rocky start, but the contact tracing app gets launched tomorrow. There is going to be real opportunity for us to then start identifying more of those contacts and helping them self-isolate. Very welcome news that there's £500 grant available for people that have to self-isolate or contacts. The council has been notified of that last Sunday, and we are in the process of putting that in place. We have got a weekly health protection board with colleagues from the NHS and others that help us to continue to manage the outbreak, and the ongoing engagement with the NHS and Public Health England about difficulties in accessing testing, and the letter from the Maher. And I think some of our colleagues in the NHS will also be highlighting the difficulties it's having. And as I said, the NHS COVID-19 app. So that's the end of my presentation. Thank you.
Chris, thank you very much indeed for going through that succinctly. So I certainly know from our pre-meet, I had a question from Cllr Gregory. Cllr Gregory.
Hi, thank you for the presentation. I'm concerned for my constituents in Shackerwell that in early September, the infection rate was the second highest in Hackney. Please, can you tell me why that was, and how it has now reduced considerably towards the least infected ward in Hackney in a matter of a couple of weeks? Can you give a bit more detail on what's been done to support local businesses and ensuring that shoppers are socially distancing and that people wear masks on buses when they're stuck in traffic? And finally, can you explain what the percentage of success rate is for test, track and isolate in Shackerwell and other infection areas in Hackney? Thanks.
Okay, got 4 questions there. I would just guess, Michelle, buses is TfL, that we may not have much control over, but I'll see if Chris has got anything to add on that.
So thank you, Councillor. So some very detailed questions, which I will endeavour to take away and give you a written answer, especially some of the issues around the particular metrics. Just really in relation to what we've been doing, these are still small numbers, especially when we get down to a ward. The availability of testing is really key. I would like to be able to sit here and tell you that we are being successful in your ward, and perhaps more successful than in other wards. I honestly can't do that. It is very much around whether people are able to get a test, whether people have confidence that if they put the effort into trying to go onto the website, they can get a test. We are doing work in all of the wards and concentrating in those wards where the numbers are high and the numbers are going in the wrong direction. We have been looking at some of the GP rates as well, so that we are able to get a very early indication where we think the rates are going in the wrong direction. And we are making representation to Public Health England to see whether we can actually get outbreak testing rather than what we have at the moment, which is kind of routine testing in order to control some of the high rates in the wards. In terms of the, generally speaking, I think the change in the guidance to become legislation is going to be very welcome by most of the enforcement agencies. Greater clarity about when face coverings need to be worn in the hospitality industry, because at the moment it is not mandatory to do so. It will be mandatory, and I think the issue around compliance of local businesses, the Metropolitan Police and Environmental Health and everybody else, it is very much about communicating what needs to happen. Essentially, if we are getting intelligence, and we are from residents and yourselves as well, about any businesses that are not complying, there will be an escalating approach to informing, to visit, and ultimately to enforce, fine, and potentially close the premises down. So there are a number of visits that we have got planned with environmental health colleagues to respond to some of the issues that have been raised. In relation to the buses, I think the compliance on buses is actually fairly good. I have been out and about, but obviously, again, if there are concerns, then it is very much an issue of making sure that does go to the relevant agency. I think that would be TfL, but obviously the message, I think, on public transport has been there for face coverings for some time. Some people are obviously exempt, and I think as we're getting more and more of those guidelines being fairly universal now about mask, face covering wearing, it will be easier, I think, for people to recognise that, you know, if everybody's doing it and you really aren't exempt, then you really should be complying. I think that's probably all the questions that I'm afraid I can answer at this stage, but I will take those away and see if we can get some further questions in relation to your specific answers around test and trace.
And Chris, just to follow up on the last point that Michelle asked about the sort of not just per se Shacklewell, but say across the borough in terms of the success of the new role we have in the in the tracking and isolating. How are we, as far as I understand it, it's typical use of private provider in the space. They pick off the low-hanging fruit, those that answer the phone, and they claim that success rate, and they give everyone they struggle to the local authority query whether we're getting any extra money for this or not to fulfill this function. So inevitably we then get people who might be more difficult to reach. How are you monitoring success on that?
So you're right, and I apologise. It cantered through my presentation and I forgot to mention it. It's a particularly important development that we have been working very hard on. So essentially, the success rates for the NHS test and trace in Hackney are not where they should be. We're not alone. It is very often around deprivation, around English not as a first language, and generally suspicion about perhaps some of the public-private partnerships and the involvement of organisations that do not necessarily have the track record that you would want to put the NHS brand onto. So I think in terms of that, what we've been working on in Hackney is if they have been unsuccessful to contact the index case, then those numbers will be supplied to the Hackney contact centre staff, and in the City of London it's going to be the environmental health officers, and then we will try to contact them using the records that we have in the council to see whether, if it's because the person's mobile phone number is not correct, we may have a record of their mobile phone. We then contact them. Yesterday we went live. There were 6 people that were referred to us. We were able to access 3 people and they were completed, which may sound like a small number, but it's a really important number because you can enter back into the contact tracing. What we're also quite keen to do, and colleagues from the NHS will be grateful for your view, is that after a couple of weeks of this, what we want to do is take all the ones that we have not been able to contact them, or we don't have a full contact details, and then pass those details over for an audit, just to see if we were working more in partnership with the NHS, would you have had the contact details? So the council will have contact details for some, but you may well have their contact details on the GP practice. We're not asking you to actually do anything with that, just to give us an indication. Let's say we have 100 people. If we were doing it with a greater data sharing, would we have been able to contact any more people? And if so, we will then go and try and get the data sharing protocols in place. This is very much a nationally driven program, we've had to go through an awful lot of hoops in order to ensure that our staff are well trained, they've got all the data governance in place, and they know, how to operate the system. These are staff that are very used to contacting our residents. There are contact centre staff in Hackney, and so far there has been, really good uptake and feedback from residents when we've contacted them to get their details. So I think it is a really important and successful development that we have developed in Hackney, and in parallel also in the City of London, and that should, I very much hope, start to increase the number of people, the percentage of those people that were identified as COVID positive, who we can make contact with, and then hopefully get those people who need to self-isolate contacted as well.
Thank you. Thanks, Chris. I've got questions from Councillor Snell and Cllr Adams, and then a comment from Cllr Kennedy. I'm over time, so can I take questions 2 together, please? Councillor Snell and then Cllr Adams, and then we'll go to Chris for and then we'll go to Chris for a final answer, and then Cllr Kennedy for his comment. Councillor Snell.
Thank you very much. On page 24 of the agenda papers, there's a record, a note that says, third bullet point, it must be noted that ethnicity was not available for about half of the records. Now, that is seriously worrying in a borough like Hackney, when we know that black and minority ethnic communities have been disproportionately affected by COVID. Could you just tell us why that is so low and what we're doing to try and improve it?
And before you come in, Chris, can I have Councillor Adams?
Thank you, Chair. So I just want to, I'm looking at the graph for the 7-day incident rate, looking at Oxidants and Shoreditch. I'm just wondering, why is the incident rate, the incident rate in Oxidants and Shoreditch is so high? Is there any particular factors responsible for that? And what are we doing to address that? And secondly, you talk about people isolating that can claim £500. What are the criteria for those people that can claim that money? Because the government will announce something, and sometimes to access is very difficult. So what are the criteria for people to access that £500? Okay.
Chris, it may be, councillor colleagues, that any ward-specific analysis Chris has to come back on, as I think he's indicated. But also, Councillor Adams, the data in the pack is a few weeks out of date now, because it's been superseded by the presentation, which was more up to date. So I don't know where I can't recall where Hoxton and Shoreditch was on the one that Chris just showed us. Chris?
It's the third highest. It is very difficult. It's very easy and very tempting for me to start to give you analysis of the data, but I think I would be remiss to do that. It is about, I think, where you have got a younger population, where you've got more opportunity for social mixing. And that may well be, I mean, that does describe my understanding of Hoxton, East and Shoreditch. So that may be part of the reason. It also may be the influx of students, and it may be actually a better availability of testing. But I think where you have got it occurring time after time, that is where we are then saying, actually, this is such a large number that the numbers have been the same for a number of periods, that is something that we do want to then look at and investigate more. I think we are looking at a very similar picture across a number of different boroughs. So, you know, where you have got those social and hotspots for socialising, that's often where you are getting higher numbers. In terms of the ethnicity, I think it is something which sometimes on a helpline, and when people have actually completed the forms themselves, when they're going for a test and trace, you're absolutely right to highlight the importance that poor record keeping means that, again, any conclusions that we draw has to be cautious, because we don't know anything about the ethnicity of those 50%. I will again take it back and look at to see whether we can send that message back either nationally or to Serco, to ensure that actually the importance of having good data entry and capture is important. In terms of the isolation money, I think the guidance came to the chief executives on Sunday. They are busy in the council working out how to implement that. Again, I think there may well be some national guidance about who is eligible. I can have a quick look now and try to type it into the chat if I can find the guidance. But there very much will be announcements, and there will be communication so that people are clear. You know, you don't want people to apply who, you know, are not going to be eligible. There is a fairly tight eligibility criteria, but there is going to be that very welcome support for people to self-isolate.
Thank you, Chris. And if you can let us know, yeah, either type it into the chat or send it to us afterwards through Jarlath. So I think we'd all be interested to learn what the criteria is for that. Last thing, I'm closing this item after Councillor Kennedy has made his comment.
Thank you. Yes, two very quick points. Just an indication to you all of how drastically the testing has fallen in London. So Kevin Fenton on a call yesterday morning said that mid-August in London we were testing 90,000 residents a week. By mid-September we were down to 65,000. So that's really a huge drop-off, actually a reallocation of testing away from London, just at a time when it looked like we needed it most. And the second thing I wanted to say was I do know a little bit about the £500 allocation. The great irony, of course, is you have to have a positive test before you can be eligible for it. So testing drops off. Money for people who have to self-isolate comes on. One of the conditions is you have to have a positive test. You couldn't make it up, really, could you?
Thanks, Chris. Okay. With that, I'm going to close the item because we're over time. Thank you very much, Chris. That was great to see the presentation, and thank you very much indeed. Next item on the agenda, item 6, is the update from the planned care work stream, and we've got Siobhan Harper, who's the work stream director. I'm not sure whether we have also Andrew Carter, who's the director of the work stream, with us. Siobhan, I mean, I think we've all had the paper. If you want to do a very brief introduction, but otherwise take it as read, or we're happy with that.
Okay, I'll just do 5 minutes then, just to give a bit of context. Andrew has given apologies. I think he can't access the Google system, so he's not been able to join us, I'm afraid.
No problem.
So I recognise it's a lot of information that we've supplied from a kind of really since the beginning of the pandemic, and the focus of the work and the main focus of a lot of the presentation is about the recovery and the restoration of services since the, there was a lot of closure of services during the peak months of the pandemic, and the work that we're doing in order to reinstate services and ensure that people are accessing the care that they need. I wouldn't underestimate the task of what that involves, but I guess some of the key developments have been the establishment of an acute alliance across North East London, kind of what Tracey sort of referred to earlier, where the providers have formally come together to deliver care, elective care, in a collaboration, using their resources collectively to ensure that we can meet the quite stringent infection and prevention control guidance in order to keep theatres in particular COVID free, so that people can have the planned work that they require in a safe way. There are plans for the development of surgical hubs for low acuity, so less sort of severe or acute illnesses and high volumes across the whole of North East London, and there will be designated sites for specific surgeries that will be developed over the coming months in order to help to deliver the restoration of elective surgery at the 100% levels that have been required by Simon Stevens as part of the NHS, the third phase recovery letter that was issued a few weeks ago. The other things I would just draw your attention to are some good news, I guess, around the fact that although we did have to delay a lot of elective surgery, a lot of cancer surgery did continue during the pandemic, and a lot of people did get their treatment during those months, and sometimes in the private sector, but also still at Barts Health, some procedures did go ahead. The main delays really are in the diagnostic part of the pathway. So there's a lot of issues around, in particular around the diagnostic tests for endoscopy, which again are mainly due to infection control procedures and just being able to get through the numbers in a more productive fashion, because the restrictions are much tighter now in terms of how many people you could see in a day. And obviously we we have an issue about workforce. People are tired. There's been there's a lot of work that's gone on, and now we're asking people to rework at levels that they were doing prior to the pandemic. So that is quite challenging. Cancer screening services are also reinstated as well. So that the message very much for those services is that they are open and available, and so people should be encouraged to have those kinds of checks on their health like we would have done pre-pandemic. The other thing I just wanted to draw your attention to as well is a bit of work we're doing around recovery from COVID. So you may have read about it, you may have heard about it from some of your constituents. There are some people who have had what's referred to as the long COVID and finding recovery quite difficult. And we are looking in partnership with our providers across acute services, primary care and mental health services to develop COVID-specific recovery pathways for patients, where we can address the kind of the complexity of multifaceted illness that presents in lots of complex ways, and making sure that we can make sure that offer is available to our residents. And then I think that I'll pause there and take any questions from the pack.
Thank you, Siobhan. Just on long COVID, I mean, I don't know whether that's also something on a public health and comms ground can be picked up. I mean, I still don't think it's talked about enough that for a certain proportion of the population, and it's not just the elderly, but if you've had it, you can have long-lasting health ramifications, and sort of a counter argument to this argument about why don't we just lock up the elderly and it will be okay. And I just don't know whether there's perhaps more work that can be done on a comms ground to let people know it's a very real risk to their health long term as well. But I just throw that out there as a comment to think about. Before I open it up, Siobhan, I think one question I've got several I could ask, but one, in terms of virtual by default and moving to that sort of thing, I'm still not completely satisfied. I know Mark's listening here. In primary care, in terms of telephone triage, we've completely got a comprehensive strategy for how we deal with the digital divide, and those people that aren't used to using devices, can't access them, aren't experienced broadband connection, the rest of it. What is our overarching consistent action plan to make sure they still have as good as access as the cohort that are on the right side of the digital divide? Do we have a comprehensive Hackney strategy, primary care, secondary care? How are we dealing with that?
So there is a piece of work that's being led by the IT enabler group, as David referred to earlier, which is led by the digital team. That is Hackney, the Hackney digital team, where we are looking to maximise opportunities for people to learn about the digital world, I guess, where they may otherwise be disadvantaged and not able to access. And we have done some specific work around people with learning disabilities being able to access actual hardware, as well as being helped to access services through that hardware. And similarly with mental health, there's been some work with personal budgets so that people can purchase their own equipment. We're also as part of our kind of general inequalities approach, we are very mindful of this being a real risk to the services that, only the people who know how to navigate services already are the ones that can often access. And if you then layer on the digital aspects on top, that could potentially create a lot more barriers. And I think that we will be looking at that in detail in our individual plans around reinstating services and asking providers to monitor the impact of who is accessing and whether they're able to access, and making sure that we have questions that are asked about that, because we make assumptions that people A, have the equipment, B, have the personal space to even receive a phone call or do an interview, a face-to-face call like this. Some people just don't have that lifestyle. They're not available. They're just not able to do those sorts of things. So we're very mindful that we need to have plans in place to address those issues.
Thanks. David, do you want to come in there?
Well, just an adjunct to that, I mean, the general policy around managing healthcare needs during COVID was digital by default, and I guess our instinctive strategic response to that was digital when appropriate, which is the approach that, you know, does help us begin to identify where digital works for somebody and where it doesn't, and then have appropriate pathways in place for those that where it doesn't. So I guess overarching strategy in development through the IT group, as Siobhan articulated, but generally from a values perspective, it's digital when appropriate is our key filter mechanism.
Right. Okay. I mean, I would just say, I mean, I think it's something the council's in a way being challenged by in terms of school kids and how they can access learning as well. So you're not obviously alone in this, but I still just instinctively feel there could be much more joined up work on that area. Colleagues, any councillor colleagues, questions? Okay, Councillor Snell.
I really do appreciate this splendid work that you're doing, but I really did have problems reading through this report. Whether we call them acronyms or initials or whatever it was, it did lose me, and I was seriously having to take double the time I'd expect and go and cross-check to make sense of it. It was great by the end, you know, when it was just sort of getting on to what you're actually doing.
Because it was the end.
No, but I mean, please, if I'm struggling to understand what all these different organisations are, then I suspect other people trying to understand this report would be in the same situation. So, I mean, we have had, I think, in the past, lists of abbreviations and what they mean. But I did find it impenetrable, but welcome the recommendations. I just wanted to make that comment because I didn't seem to have an email address for you, so I thought I'd better just make it live.
Okay. I mean, I appreciate the feedback, and I think I suppose that, you know, it has been quite an intense few months, as it has been for everybody. Now, you know, I guess some of that just got a little bit lost in my thinking about you know, who would know what things mean, and that's a very helpful reminder actually, because you just get so immersed in the day-to-day, sometimes you just forget about how it might read externally. So we can pick that up.
I'm just checking whether there's any other Councillor Gregory.
Sorry, I just turned the video on. Hi, I just wanted to ask about the cost of medicine, because on a couple of occasions when I've been on the phone to my GP, they've talked about the cost of the prescription. We've had a discussion whether to have the cheaper medicine or the most expensive one. I'm just wondering if you have any thoughts on that. Thanks.
Well, there's no doubt that there are varied costs of medicines. Generic medicines versus you know, they cost less. Some medicines can be very cheap, like ibuprofen, for example. You know, if you buy that in a generic form, it's much cheaper than if you buy it with the Nurofen label on it. So that's something that is prevalent throughout all medicines really. And we do encourage our GPs to be mindful of prescribing costs, because they have, you know, been incredibly efficient at ensuring that we deliver best value around our prescribing budgets, and we you know, make sure that we offer equitable and just as effective medicines, potentially at a lower cost. I don't know whether Mark Rickets might want to make a comment as a GP on that, but that's something we do actively encourage.
I mean, certainly there's on the clinical system GPs use, there's a prescribing, obviously there's an element of it which has got the whole of the prescribing formulary embedded in it, and loads of kind of useful kind of checks. It'll automatically tell you if you're going to have a potential cross reaction to two drugs you might be prescribing, all sorts of very helpful stuff. And it also pings up saying, do you know that cream is exactly the same constituents as this cream, and that one costs £10 a pot and that one costs £1.50. Do you still want to proceed with your first one? And you can put yes or no. And you may put yes because there may be some overarching reason why it should be that one, but it should be the unusual. I mean, usually just go with it. It's the same stuff. Just go, and all that money, which is at £8.50 in that case, it all gets used for other things. you know, and so you can make the case that it allows us to invest in other services and things. So yeah, we are minded on this, and actually we've got systems to help prompt the clinicians in the moment they're doing the prescribing to think, oh, actually, they don't need to do that. We could do this. I mean, but there are occasions where you do prescribe specific things. Sometimes that's for very clear medical reasons, where in epilepsy you really do need to have the same tablet by the same make. There are reasons for that because of efficacy and things like that. And that all comes up as well on that system, and it's constantly upgraded. So there are reasons, and sometimes those reasons are very much, you know, honestly, doctor, I've tried both creams. I don't know what it is, but there's something about that one, and it just does the job, and that one doesn't. And you have a sort of conversation which takes a little while, and then you reach a consensus. But by and large, you go with the cheaper option.
Thanks,
I
Mark.
do find it odd, though, that my doctor's having a discussion with me. Well, would you like the cheaper one, or shall we give you the more expensive one? I just find it a bit strange.
Well, anyway,
I think, yeah, GPs have just got very used to being. I think they've been about being efficient with the health service. I think it's just a culture that's quite embedded now in a lot of what they do.
We've tried to develop those commissioning ways of thinking in a normalised sort of way of being, without it being a kind of onerous task. And actually, that's helped our health economy run way more efficiently, really, and therefore we use the money more effectively.
Can I just ask, just before we sort of close up here, Siobhan, in terms of the centralisation of surgical hubs, Tracey touched upon some areas where there are possible patchy services at the Homerton, and some areas where the Homerton will become the specialisation for. What's the process? Is a consultation going to come out? Are we going to see a document coming forward to say in these and these forms of elective surgery that we propose, this one goes to Mile End, this one goes to Whips? What's the
yes, my understanding is that there will definitely be the Acute Alliance will definitely be doing something at the joint overview and scrutiny committee around the proposed hub sites. And I guess Jane Milligan at our AGM last week, I don't know if any of you listened to that or were dialed into that, but she made that commitment that the changes were not substantive, as in if there were any long-term changes as a result of the COVID arrangements, that they would be formally consulted on, and any equalities impact assessments undertaken, etc. Really, these arrangements are in response to trying to clear the waiting lists, really. That, you know, I mean, for City and Hackney, we have got about 17,000 people on the outpatient waiting list just ourselves, you know, so there's a lot of people that need to be treated. So I think that's really the objective in the short term.
And with we're familiar with this sort of, very familiar with this sort of argument about specialists query, improved standards, and professionals working better together, sharing vis-a-vis transport and distance, and that debate and how it runs out and the different factors. But in terms of, say, those Hackney or other residents from other boroughs that are being asked to travel a significant distance and are vulnerable, however we class that, what are we doing in terms of giving them clear instructions, possibly supporting them with transport? How much is that aspect being thought through?
A great deal, actually, because as part of the recovery, all of the trusts have been having, because of the initial, I don't know if you were aware, but the initial infection control guidance for patients was really quite, is really proving very difficult to get, because people were being asked to self-isolate for 2 weeks before coming for their surgery. That has since changed, because it was proving really to be virtually unworkable for lots of people for lots of reasons. But as part of that individual conversation that hospitals have with patients when they're booking them in, they will be looking at transport as part of that process, and, you know, how people can attend. And, you know, for example, if you have a day case procedure, you can't attend unless you have someone coming to collect you and take you home. So all of that is being given a lot of attention as part of the rebooking process of people in for operations.
Fine. Okay. Thank you. I think with that, then I will close this item. Thank you, Siobhan. I mean, one of my questions was going to be, when do you hope to get back on track? But I think with possibly a second one, I mean, it's just, I guess we don't know where we're going to be.
We don't really know. Yeah, I mean, but I should say though that, you know, the real message is that there is no intention to close services like we did last time. At the moment, you know, that is important that it was a sort of unique situation, and hopefully we won't have to get to that situation. We'll be able to continue with existing services, and all the things that we've learned and all the provisions that we've put in place to maintain safety will now come into good fruition, so that we won't have a load more people joining the waiting list, really.
Okay, thanks, Siobhan. Thanks very much for your presentation and time.
Thank you.
With that, I'll move on to item 7, which is the Healthwatch annual report. We're joined by Jon Williams, who's the director, and also Malcolm Alexander, who's the acting chair. Welcome to both. Who's going to kick off for us? Is it Jon? Is it you?
It'll be me. Can you see the presentation, or shall I present it to you?
We've got it in our pack, and I have to say my preference is so I can see everyone on the screen. If you just don't share the presentation, and
okay, I'll just read to it. Firstly, apologies from Malcolm, having IT problems, so he apologises that he can't make this meeting. He's disappointed, but he certainly tends to turn up in future ones. And he's our interim chair. We will be looking for a permanent chair in due course. So okay, so I'll just quickly go through the presentation. I'm conscious of time. So for us, this year has been a year of kind of consolidation and progress, really, after 2018, which was a difficult year for us. We are back on track in terms of delivering our contracts, and the organisation is solid and moving forward well in terms of kind of developing its board as well. So we're in a much better place than we were in 2018. Although it was at the end of the year, COVID was the big impact that we saw on residents and our service. It has impacted our ability to do face-to-face work. That is a key way of operating, and so we've had to kind of adjust to that world, and taking account of the kind of digital conversation just now. We are thinking about working particularly closely with the voluntary sector and the community groups who can give us access to those people who are digitally excluded. We expect that digital exclusion to get worse as well because of the economic climate. In terms of satisfaction with health services, slight slip in this. I'll say a bit more about that later, but there is a downward drift, what we're seeing in terms of kind of satisfaction. But in terms of funding, council funding is going to get tighter. As the CCG funding, we suspect, when they start putting in totals as opposed to the flexibility they have now. And we expect our funding will also get tighter. Generally, the situation is going to be financially tighter for everybody. And some services have been regional. We already talked about this in the meeting today. This is the impact of the long-term plan. This is going to have a big impact on patients. We do think there's got to be strong consultation around this area, for the simple reason that this is going to be a lot of shifting around, and it's going to be a lot of big changes as well. So I kind of take the point that was said earlier about, you know, it's all going to be consulted on, but it better be, because there's a lot of kind of frustration, I think, at the moment about the way things are happening and the top-down approach.
Are you talking about the surgical hubs there, Jon?
Surgical hubs, but the things like the move to dementia services to East Ham, all those things, they need to really kind of think about the way they involve people in those issues. Yeah. Moving on to my next slide, which is number 3 in your pack. As this is essentially what Healthwatch do. I'll move swiftly over these because hopefully you're familiar with those. Essentially, we're supposed to get people involved in scrutinising and commissioning of services, make sure people monitor them, get those views, and make sure people pay attention to them. One thing we're particularly eager to do and make sure happens is that when we publish reports and make recommendations, people act on them. And we're certainly going to be pushing that more, because we do think people should kind of listen to what the public wants and actually respond to that in a way that actually kind of respects their views. Signposting continues to be a big issue for us in terms of kind of the very diverse communities in Hackney do need good access. There is a struggle in the system about kind of trying to get a good system going. We had iCare, that is now being absorbed into Find My Services. I think we're getting there, but it's still a struggle. And we also formulate standards of use local services. We're having a meeting on dental services on the 29th of September, where we're having the head of dental services to come along and talk to us about how they can improve these things, particularly because it's been challenging over COVID. Moving on to my next slide. in terms of what people were telling us. As I said, people are less satisfied with local health and care services. There's a 2% drop we detected last year. But the 60% is positive. But that's on top of a 5% drop the previous year. So there's a general pulling down that we're seeing, and we're concerned that this may be a kind of a slow slip. Communication needs to be better. This is a common theme that we see pretty well every year, but it just doesn't seem to be improving. It seems to be very hard for services to actually communicate well with the public. Letters are not kind of clear, things that are missing. People have to repeat themselves. It's still a challenging area. Certainly from our kind of engagement on the NHS long-term plan, people were keen to protect the full range of services at the Homerton Hospital. But we heard from Tracey earlier about the fact it doesn't have the full range of services there anyway. But the kind of continued reduction, like in pathology and mental health services, is a slow kind of weakening of that service. And also, one of the key issues remains mental health. Long-term mental health also has to have that support. We are particularly concerned this is going to be a growing area with COVID. What people also told us about is that most people are getting good compassionate treatment, which is excellent to hear. And also the clinicians and the practitioners are really kind of getting people feeling they're involved and supported. So there's I think there's a really good dialogue going on between the practitioners and the clinicians now. We are seeing increasing complaints about service access, so people aren't getting to the services they want to, and it'll be interesting to see how people feel about this move to digital and how they feel about that. Like I said, we notably, as I said, I mentioned communication once. I mentioned it again because it is an issue for us, but also waiting times, and again, that's going to become a bigger issue given what's happening at the moment. We're very proud of our volunteer base. It's 43 people who've given us nearly well over 2,000 hours of their time to improve local services. They're kind of a key way we operate. Our board's volunteers, many of the people who do our engine reviews and collect feedback for us are volunteers as well. Without them, we would not be the organisation that we're able to achieve. We're also very pleased the way the volunteers can move on to do other things, so they can go and get jobs and things like that. Next slide is really about helping to find your answers, which is about signposting. Again, it's kind of the focus of our areas, and these areas that kind of make us want to look into these areas more. We want to look further into support for disabled people at the moment, because we're hearing that's a really struggling area. I've been hearing in a number of meetings now that this is a kind of a critical area that people feel quite abandoned. COVID-19 is also kind of a massive issue for us, and we continue to kind of look into that issue and see how our supporters and others are dealing with it. Mental health services, NHS complaints are also important. We're actually reviewing our Hackney complaints charter at the moment. The council are a signatory. We're very pleased about that. We want to extend it to opticians, dentists, and others, and GPs particularly, who seem to be avoiding it at the moment, because we think it's really important that people really understand how to make complaints. Complaints can really help organisations improve. We certainly, and we continue to give voices to the Selham Her residents. We were very pleased to work with the council of the Housing with Care service, which, as you know, was kind of inadequate, rated by the CQC, and it's certainly massively improved since then. And we really kind of welcome working with the council to kind of get the residents' voice and their carers and relatives' voice in there as well. Migrants has been a long-term area that we've been focused on. We did a major report last year on migrant health. We continue to be concerned about the hostile environment towards migrants and the fact they're charging. Charging stops people going to hospital. It's simple as that. That means things get worse to them. It's not a clever way of doing things. Older people continue to be a focus, and we consider to celebrate what older people can do and make sure that they're going to get the service they want. Again, we're kind of focusing on those again this year because for the simple reason we're concerned about the isolation people are feeling. Although we are hearing that some people are more connected as well, which is good. And also people with sickle cell disorders, we think that's a area we want to continue to focus on because of Hackney's kind of prevalence of that condition. But it's not so widely seen across the region, so we want to make sure those services are maintained. Let's see. In terms of kind of building future public involvement, we're heavily involved in integrated commissioning and will continue to do so. I co-chair the Integrated Commissioning Communications Enabler Group. We are interested to understand fully how public involvement will be taken going forward, both locally or at a neighbourhood level, which we think should be much more moving away from kind of having panels and things like that, but moving towards a much more closer relationship with the community and the community development process. I think we're kind of aligned to what the Hackney CVS are doing, but also what the council's approach to kind of community development. So the neighbourhoods are going to be a major push for us in terms of making sure that people can actually understand what they are. We operate things called an involvement alliance, which is also kind of helping organisations work better together and actually kind of support people who are hard to reach more effectively. And we continue to push co-production as the way to do things. We think that needs to be extended and probably pushed more into a more wider equalities and sustainability process. So widening it out. Finally, these are our, you've seen our finances. We continue to be funded well by the council, as well as the pressures they have. We have lost some funding as we lost the, we usually gave up the Healthwatch City contract. So that we've moved on from that, but we continue to be well funded by the CCG for a number of projects as well. I'm happy to take any questions.
Thanks, John. Very helpful, good presentation. And, you know, as I always feel, I think you strike clearly you're funded by the council and the local NHS, but at the same time, you've got to hold them to account. And I always think you do that balance very well.
Thank you.
Questions? I think Councillor Snell.
Well, John, every time this report comes up, I compliment you on its quality and its accessibility. And we're spoilt when you do a presentation on top of it, because your annual report is, as ever, wonderfully accessible. I think you welcome us, because one of the good things about it, it talks about your last year and then talks about where you're looking next year. And I'm hoping that you welcome suggestions from this committee on things that you might look at. It seems to me that you know, my experience of the NHS, the health services are wonderful when you get into them, but they can be an absolute pain to find your way in sometime. And I think the problem is they're easy to understand for people on the inside, and then they don't understand that, you know, muggins like me comes up and really hasn't got a clue what the procedures are. In particular, one thing I find a very low level of awareness of, we've got this wonderful thing, the Confederation, that sets minimum standards and does its own checks for GPs meeting those minimum standards, those requirements. I mean, it's a wonderful way for us, in theory, to get consistent approaches across all GP practices. But I just feel that things that I think are in there, like being able to ring your a GP and get a same-day appointment or whatever, or, for example, the pathway, you know, the fact that everyone who is near end of life should have had an assessment of how they'd like their life to end, and that should be available on the computer record. Those are really excellent things, and yet the number of times I speak to someone, a friend of mine recently lost his mother, and they just didn't know that existed. So I think there's a real piece of work to actually look at awareness amongst patients of those standards. I'm hoping we can rely on law and the Confederation to make sure that GPs, and we probably need a report very soon, that GPs are doing those things we're asking of them in these difficult times. But I wonder, John, have you done an across-the-board survey, not specific to one practice, but just the whole lot, saying how much are those basic requirements understood, and are people able to use them?
I think it's a really good point you make. It's kind of we haven't actually done a survey like that, but one of the things we have been thinking about is that we want to talk about patient rights a lot at the moment, and also service user rights, so people can be clear, a bit like we did with the complaints charter, where we set out quite clearly what should be expected. I think we could do something like that as well, and we'll be happy to work with kind of people like Laura Sharp, GP Confederation, to kind of make sure that could happen, because I think it's kind of you know, people don't know what their rights are, don't know what they should expect. And I think if we can put it out in a very simple, straightforward way, That would be very helpful to the patients, because that's what the complaints charter was about. But I also think we should be actually surveying and making sure that the GP surgeries are doing things to a consistent standard, and that people can hold them to account. So I'll certainly take that back. As if John wants to put it down to an action for me, I will take it back and we'll see what we can do.
Thanks, John. I mean, just dovetailing from that and what I said before about digital divide. I mean, I think from other councillor colleagues, the most regular bit of feedback I get is the digitisation of sort of access to primary care. Yes, it's great if you know what you're doing, but for those that are on the wrong side, not being able to get a GP appointment and feeling like they've been shut out of the system. 4 or 5 other councillors have come to me with this, saying that they've experienced it. So it's how we have a, and I'm saying, I know Laura's listening here as well, a joined up approach in terms of access for those that are on the wrong sides of digital divide, and what is best practice elsewhere, and whether there's a bit of work to be looking at that as well. So they know their rights on that side, but also what is best practice we can be working on.
I think that's a major challenge, the digital divide, because I'm expecting it to get worse rather than better at the moment, for the simple reason. Although there's going to be a huge amount of effort, I think, and I'm really pleased about seeing what the effort around Integrated Commission, what they're trying to do around kind of breaking that digital divide. And I'm also very appreciative for what Hackney CVS have been doing, because they've been making a huge effort in this area. But given the state of the economy and where it might be going, people are going to be struggling more. We're going to see more unemployment. We're going to see people more struggling. The divide's going to be created, be developing and splitting, I fear. So I do think it's there needs to be a major piece of work with all the, and I think maybe through Integrated Commission is probably the best way forward in some ways, because the way it brings all the partners together, to actually think about how we can actually kind of work to make sure that we work with the communities, the community groups, the faith groups who do have access to these people, who can get messages to them, and we can figure out a way, because it is going to be a big piece of work, I think, to actually really understand what those issues are, because a lot of the people who are a bit on the wrong side of the digital divide are very hard to reach in the first place. Those seldom heard voices. So I'm fearful, really, at what I'm seeing at the moment. And the reason I'm so fearful about it is because we did a survey, the NHS Community Voice Survey. Didn't get many people replying to it, but it replicated what we were seeing across other areas. Essentially, there's a lack of confidence now in what governments are saying, both local and central government. We expected to see central government get the hit, but we were surprised to see local government was also being mistrusted. But there's also a lot of people just not listening as well. So you've got a real problem developing where people are just not trusting systems at all. And I think it's really important that as a system, we work together very closely with kind of the community groups and faith groups and others who can give us access to these people, to make sure we can actually make sure that they don't disappear, because that's my fear at the moment.
Thanks, John. We've hit 9 o'clock, so unless I see any other questions from colleagues, I'm going to thank you, and for as Councillor Snell has said, for another very helpful report. Keep up the good work.
Ben, can I just say how much we'd also welcome that sort of work that John describes about access, really trying to understand how much this is, just, we know that there's about, I don't know, well, the last time we had figures was about 1.6 million consultations a year for people who are registered in City and Hackney with GPs. So that's a lot of consultations. So is it a problem of just some practices not being very well organised? Was it that day there was somebody off sick and they couldn't get cover? Is it more a systemic problem? How big a problem is it for how many people? It's very hard to really get a sight of that, because you can send out questionnaires, you can etc. etc. So I would, the more information we can get to really understand when things aren't going as well as we want, we really welcome. So I just kind of want to put that out there as well. It's not only your committee welcomes it. I think we would all welcome, getting as much information in this regard as possible.
Yeah, and I think, as I said before, if there's scope for Laura to do a bit of work on what is a joined up protocol, maybe for GP practices, for a way to challenge this for people who can't access.
Yes, and
to have a consistency standard but to know what they need to do. Whether I appreciate the difficulties in terms of reserving a certain number of appointments, or I appreciate it's fraught with difficulties of how you then implement it. But the current situation of people sort of feeling the door shut on them when they just want to speak to their doctor and they can't.
And is it disproportionately affecting certain people, certain people with certain types of problems in certain types of background?
Thanks everyone. I'm going to call that to a close. And then just last items, the minutes, which Giles kindly pointed out at the number 8. Can I just take those as agreed, please, councillors? Thank you. And work program. Thank you. Work program is there. I think we've got certain items in, and I think we'll also keep a degree of flex in terms of where we are with COVID and needing an update with respect to that. And just to update members, it's looking very much like the inner North East London committee is the rotating chair is due to come to Hackney as in February. So that will possibly, as some of these things come down the line in terms of the integrated CCG and surgical hubs, we'll have a good oversight of that. So with that, unless there's anything else, I'll draw the meeting to a close and thank everyone. Thank you.